Hello, and welcome to the Prostate Cancer Virtual Disparity and Early Detection Summit. Riverside is excited to host this event series in partnership with the Hampton Roads Prostate Health Forum and other healthcare systems. My name is Mary Kleckler, and I am the Prostate Cancer Oncology Nurse Navigator for Riverside Health System. As the Prostate Cancer Navigator, I'm here to guide and support prostate cancer patients throughout their cancer journey and to assist with any patient's concerns or barriers to their care. Prostate Cancer Navigation is a free, specialized service that we provide for our prostate cancer patients here at Riverside. Thank you for joining us this evening, and now I would like to introduce Mr. Charlie Hill, President and co-founder, Hampton Roads Prostate Health Forum.
Hello, I'm Charlie Hill with the Hampton Roads Prostate Health Forum, and we are delighted to welcome you to this first session of 4 sessions about prostate cancer. When you leave this session, we want you to know a lot more about the prostate cancer problem in this country and particularly our region, Hampton Roads. In addition, we want you to know more about the contributors to other problems that prostate cancer may embrace, such as disparity. And finally, we want you to know how important early detection is. One unique thing about this session and all of our sessions is that we will capture all of the questions and provide the questions and the answers on our website as soon as we can. We have 2 outstanding panelists. The first will be Dr. Ifani Ani. He's a urologist with TPMG, and he will kick off. So one clear thing is the less I talk, the more time the docs get a chance to talk. So Dr. Ani, over to you.
Hello, good evening, everyone. My name is Ifani Ani. I'm a TPMG urologist, and I'd like to go over and talk to you more about prostate cancer and why it concerns us, especially for the Hampton Roads area and especially for African American men. Slide up, please. Next slide. Next, okay, thank you. So prostate cancer has been increasing over the years. Initially, it had decreased as a result of screening for prostate cancer, but there's been a significant amount of controversies that surrounded prostate cancer screening. So as a result, the United States Service Task Force had made several recommendations that have been updated, including where it was not recommended to undergo prostate cancer screening with PSA testing. However, that's been revised, and it is recommended with a grade C, but it is important to make sure you have the conversation with your doctor, whether it's the primary care doctor or the urologist, to understand more about prostate cancer. This is some information to kind of give you a sense of the increase since that recommendation was revised. In 2017, the estimated prostate cancer incidence was 161,000 and above, and the death rate at that time was estimated at 26,730. Next slide, please. And as you can see here, the estimated new cases in 2020 went up to 191 plus thousand, and the death rate climbed up to over 33,000. Next slide. It's important to understand the stratification in terms of age range that prostate cancer is diagnosed. As you can see in this graph, the significant amount of prostate cancer are diagnosed between the ages of 65 to 74, but majority of the bulk of the diagnosis range from 55 to 80s, and with a median age of 66. Next slide. This shows us some information about the new cases of prostate cancer diagnosis per 1,000 as it relates to ethnicity. If you look at the graph, you can see that when comparing white to non-white, there's a significant amount, especially for blacks or African American, a significant amount of disproportionate diagnosis of prostate cancer. As you can see, 102 for whites versus 175 per 100,000 for blacks. And the difference is significantly noticeable, especially when you look at Asian and Pacific Islanders or Indian American Indians, excuse me. Non-Hispanics, as you can see again, have a higher incidence of diagnosis of prostate cancer. Next slide, please. This shows you the death rate per 100,000 based on ethnicity as well. And you can see the same pattern is also apparent. There is a 2-to-1 ratio in terms of death rate of blacks compared to whites when it comes to prostate cancer. And patients of Asian or Pacific Islander descent have an even much lower risk of death from prostate cancer, as they are associated with much lesser incidence of prostate cancer as well. Next slide. So in summary, lifetime risk of diagnosis of prostate cancer is approximately 11%. However, the lifetime risk of dying from prostate cancer is about 2.5%. Interestingly, when you have the autopsy, approximately 20% of men diagnosed with prostate cancer during autopsy may range between the ages of 50 to 59 years of age, and more than 33% range between 70 to 79 years of age. Also, 2/3 of men that die from prostate cancer are over the age of 75, and this beckons the importance of early detection, because most of these men that are dying from prostate cancer don't die from localized prostate cancer. They die from metastatic prostate cancer. And these are the type of cancer we'd like to prevent, which are the ones that do end up killing people. Next slide, please. African American men have a significantly high increased lifetime risk of death from prostate cancer compared to any other ethnicity, which we witnessed on the graphs from previously, but their lifetime risk is about 4.2% compared to Hispanics, that is 2.9%, and even less than that compared to 2.3% for white men and Asian and Pacific Islanders of 2.1. Next slide, please. So now it's important to isolate the Hampton Roads area. This is a data depicting the health districts and looking at prostate cancer incidence and mortality, and breaking it down in terms of favorable ranked as 1 and unfavorable ranked as 35. The red arrows to the left identify Chesapeake, and when you look at its rank for incidence of diagnosis, it's ranked 26 out of 35. When you look at its rank for mortality, it's ranked 29 out of 35. And you look at Hampton. Hampton is ranked 35 out of 35 in incidence of prostate cancer, and it is ranked 31 out of 35 in the mortality rate. Next slide, please. And finally, Portsmouth. The incidence rate for Portsmouth is at 23 out of 35. However, its mortality rate in ranking compared to the rest of the health districts is at 35 out of 35. So these identify some of the issues that we have with regards to prostate cancer in the Hampton Roads area. And we need to do a little more work, which is the reason for these summits, to be able to educate our community about how prostate cancer is impacting our men and how it is impacting our families, to be able to understand what we can do to change these statistics. So it is important to be able to convey these information, and hopefully the more we do these, the more education and early detection that we provide within the community, the more impact we can make in changing some of these statistics. Next slide, please. So I'd like to thank everyone that is participating for this and encourage you to continue seeking more knowledge about how we can make changes with regards to prostate cancer. Thank you.
Thank you, Dr. Ani. Our next speaker is Dr. Jordan Asher. He's Chief Physician Executive and Senior Vice President of Centera Healthcare. After he finishes, then we will address the questions that you have. Hopefully there will be lots of questions. Over to you now, Dr. Asher.
Thank you so much. Really appreciate being invited to share some words this evening, but more importantly, to talk about this really important topic. Not only prostate cancer itself, but the health disparities that we are seeing across the country, and more importantly, as Dr. Ani brought up, here in Hampton Roads. Just as a little bit of background, I'm an internist by trade, practiced for many, many years, and dealt with this on a regular basis in my practice. So the first slide that I'd like to go over is sort of the introductory slide. So let's go ahead to the next slide. Is a slide that you saw before that Dr. Ani showed. But I also really want to talk about it to drive the point home, is that prostate cancer disparities is the largest of all cancer disparities. So when we talk about racial disparities, I also want to put this in context to all the other disparities that we know and bring up that this is the largest healthcare disparity. And when we talk specifically about Black and African American men, as stated earlier, twice as likely to die of prostate cancer, which I think is a very important point because at least when I went through training and some of the data Dr. Ani showed, basically the thought was you had men have prostate cancer when they die, but they don't die from prostate cancer. And that is definitely not true. It is 78% higher incidence rate. Also, to that age disparity, African Americans are more likely to be diagnosed at a younger age. And that's important when we talk about screening and early detection. And I really want to talk about early detection and quit calling it screening, because that does bring up a lot of issues. And also, the younger you are, it seems to be, as stated earlier, that the much greater risk you are of having an aggressive cancer, hence why it's usually found when it's already spread or metastatic. It presents with more advanced and aggressive disease, as I just mentioned, which makes treatment markedly more difficult. The next slide begins to talk about some things that are modifiable and not modifiable as it relates to prostate cancer. It is found that high calcium, low vitamin D, low lycopene, which is found in tomatoes and different things, and high red meat intake is all found to be associated with increased risk, as well as being overweight or obese increases risk. And so as we think about modifiable risk factors and things that we can do, we do need to keep this, take this into account. Also, when we think about racial disparities, we have to think about our culture within the context of those racial disparities. So as you look at this, you can begin to think about, what's my diet like? What's my exercise like? And I think that becomes very important. And as the next slide, we talk about physical fitness a little bit more, there's a very interesting finding when we talk about body fat and exercise, that in fact, in white men with prostate cancer, it was found that exercise did not really change the incidence, whether you exercised a lot or not at all, as related to prostate cancer. However, among Black men, it was found that engaging in exercise, those that engaged in exercise, in fact, had a lower incidence of prostate cancer than those Black men that did not engage in exercise. Now, that is relational, meaning that is just things that we have seen. But logic would say that if we want to improve our chances of not having prostate, modifying our diet and physical fitness can make a big difference. Now, there are obviously, on the next slide, we talk about things that we can't modify. In other words, I can't change your genetic abnormalities yet. And those are things that are not modifiable. Obviously, your age, I can't make you younger. African genetic ancestry, family history of prostate cancer, and common genetic variants. When we talk about genetic abnormalities, it's important that more research needs to be done in this area because we can begin to learn about those genetic abnormalities, check for those, and also think about our treatments very differently. And one of the big issues we have as it relates to racial disparities in African American males when dealing with prostate cancer is that fewer than 250 prostate tumors have been studied. And this really gets to an issue of one of the things that we need to do within the science community is look at these racial disparities and study them within the context of knowing that African American men have a much higher incidence and a much higher rate of death due to their prostate cancer. The next slide really begins to get into testing and treatment. And if you notice, I labeled this testing and treatment because as Dr. Ani pointed out, there's been a lot of conversation around screening for prostate cancer and the validity of it. Now, part of the problem with that is when I talked about prostate cancer is not studied a lot in African Americans, that data that drove that category C really has a mixed, doesn't have a good heterogeneity of participants in those studies. So there very well is likely a difference between white and black males as it relates to the value of PSA screening. And when the incidence is twofold higher and the death rate is so much higher, as an internist, I don't really view PSA screening in black males. I view it as detection and early treatment, because if we don't catch it early, we cannot treat it. Greater mortality benefits for high-risk groups, and is another issue, is that we have this mortality difference. Also, we need to make sure that we have access to and utilization of healthcare, which is another key factors in racial and ethnic disparities of all types. So we talk about making sure we diagnose and begin treatment early, but in order to do that, two factors have to occur. Number one, that we do it, and number two, that people are willing to have it done. So when we talk about cultural disparities and we talk about PSA screening and rectal exams, so I can feel your prostate, we have to remember that I need to do it, and people need to have it done. Now, early detection alone will not eliminate all the disparities. We also have to do a lot more science and relationship between biology and underlying racism that I mentioned earlier. And this really gets into our science and how we really think about this. I do want to bring up that we also think about artificial intelligence, but we have to be very careful because artificial intelligence is just using a lot of information and data to sort of predict the future. However, if all that data is based on what I would consider inaccurate or suboptimal information, not inaccurate, but suboptimal based on the number of people that have been looked at, then we run the risk of continuing disparities and even making them worse because we begin to predict the future on the wrong information. So hopefully I've left it for a lot of questions and time to discuss, that this gives you a little bit more flavor of those items that we can change, we can't change, and also the issue we have on our data itself and our study from a scientific standpoint, as well as PSA screening and making sure that we not only think about it as screening, but focus on it as early detection and making sure that people are willing to have it done, and making sure that even though physicians are in this quagmire about whether we should be doing PSAs, that we have to be in partnership, meaning if it's important to you, it needs to be important to me. The next slide is really just a bunch of references. I won't go through them, but this is just all the information. So Dr. Hill, I'd like to turn it back over to you. And I call it purpose.
All right, thank you, Dr. Asher. So far, I haven't seen a flood of questions come in, but we do have some that we'll pass on for the experts to speak to. The first one is, can women have prostate cancer? Dr. Ani.
Men cannot have prostate cancer. Only men have a prostate and women don't have prostates.
Thank you. Dr. Asher, at what age should a man start regular screening?
I'm sorry?
At what age should a man start regular screening?
Dr. Ani, would you like to take that? I think the
Sure.
data is showing about 55, but for African Americans, I think it should be younger.
Yeah, it's a little bit controversial, and part of that controversy again has to stem from the whole discussion with the United States Preventative Service Task Force. On average, we typically will say a patient that is considered average risk, and the average risk falls into no family history of prostate cancer, typically Caucasians, usually would say about 50 years of age. If the person has family history of prostate cancer, and when we consider family history, we're talking about a first degree relative, like a father or brother with prostate cancer. Typically, even though sometimes we can count like grandparents or grandfather, it really doesn't factor as much into that first degree relative. Those patient subsets really should start screening in their 40s, so 45 or 40. If that patient has two first degree relatives, like two brothers or a father and a brother that has prostate cancer, they really should start at least at 40. But typically, you want to get a baseline of PSA test at 40. Generally, because of the significance in terms of for African American males and risk of prostate cancer and the incidence of prostate cancer and mortality rate, typically we're suggesting PSAs done at least a baseline PSA at 40, and then from there you can adjust. But it is important to at least between 40 and 45 years of age to get a PSA done. When you look at some of the societies like American Cancer Society, American Urological Association, a couple of the other members, there is no consensus in terms of what age you should start screening, especially for African American males, just because there's not a lot of issues in terms of studies surrounding that. And this is why we're talking so much about health disparity, because once we gather those information, every data set tends to point at early detection and a younger age of early detection. And just like Dr. Asher mentioned, we should really focus on it more as an early detection, not necessarily screening.
Yeah, and I would just like to add to that a couple of points. Number one, I really want to layer on the importance of the research component, because those guidelines won't ever change until we do the research and we find it. Number two, remember a PSA is a number at a point of time. And what's also very important is seeing the change in the level over time. And there's a range of, quote, normal. I think it's very important to remember that if you're on the high end of normal and it goes up, that is very different. Or if you're in the low end of normal and it doubles within a year or two, that is also could be a concern. And so that's why it's really detection and follow-up.
Dr. Asher, let's stay with Dr. Asher. What factors lead you to recommend a prostate cancer biopsy?
From my perspective, and once again, there's no consensus on this. So now we're getting a little bit of the opinion of Jordan, and I could be corrected. Please jump in when I'm wrong. I tend to be aggressive, meaning if I see a PSA that is elevated, or if I see one that has gone up, okay, I am very quick to refer to my colleagues who can do a prostate ultrasound. Also, unfortunately, also if I feel anything on digital prostate exam, if I feel anything to me that feels abnormal, I also want to be aggressive and to check it. Unfortunately for me in practice, my ability to feel all the way around the prostate it was difficult. So I tended to be more aggressive on my referring. And I think clinicians have to be respectful that the prostate, neither one of us showed any pictures, but it's basically a ball. And when we try to examine the prostate, it's not always have the ability to feel the entire prostate.
Thank you. Dr. Arney, building on what Dr. Asher just offered, at what level should a person be concerned about the PSA test? Are there any particular numbers that should alarm the person, or is there some other way you should look at that?
PSA is very complex. Dr. Asher clearly is making a good point, but I'm going to detail a little bit more information in terms of how you want to look at that PSA. Clearly, there are certain PSAs that when you see them, it's very alarming. If you see a patient with a PSA in their 20s and 30s and 40s and 2000, that's very alarming. However, there are patients that would have certain PSAs that you want to evaluate, and those are not your normal PSAs. So, for example, if you have a man, let's say they have a PSA, you have a 50-year-old man, 50-year-old man, and he has a PSA of 1. When you look at the normal reference range, that PSA reference range says 0 to 4 is normal. And then you see that patient back a year later, and that PSA now has gone from 1 to a 3. That PSA, based on normal guidelines, says it's less than 4, so therefore it must be normal. Well, that's not normal, because there is what we call a PSA velocity, which talks about how the PSA has changed over time, and in no situation that's a red flag. So you have to look at that. Just the same, you can have a man that has had a PSA done, and that PSA is 5, for instance, and you evaluate that man, and everything seems okay. You do the digital rectal exam; it's normal. You do you discuss with the patient, and you probably even get a biopsy or MRI of the prostate, and everything is normal. If you see that patient a year later and the PSA is 5.1, there's no alarm. You see them the next year, it's 5.2. There's no alarm. So in that scenario, that man's PSA is above 4, which theoretically, again, is less than 4, but yet there is no significant red flag. So what we have to understand is that what is the historical origin of the level PSA of 0 to 4? Why is that what we use in our laboratory? Well, it was used because back in the 90s or late 80s and early 90s when PSA was discovered, these were the numbers that was used when PSA were being studied. And the 0 to 4 was being assessed as being normal, and anything above that, that person needed to be biopsied to rule out prostate cancer, to increase the sensitivity to be able to pick up prostate cancer. So those are the origin, but sometimes it doesn't quite work well. So there are certain adjuncts that you have to add to that total PSA, because sometimes we also use what's called a free PSA and percent free PSA to get more answers. And then there are other tests like 4K score, PHI test. So there's different things we can use to get more information to increase our detectability of prostate cancer.
Dr. Arney, would you... Go ahead, Dr. Asher.
And those other tests that are important, because another issue I used to run into with PSAs is, that other things can cause your PSA to be elevated. Infection in the prostate, and we need to avoid there's some implicit bias a lot of times with clinicians of saying, oh, that's just probably a little infection in your prostate, take some antibiotics, and then forget to bring them back to check it again. And so that's why talking about PSA is so important, because lots of things can make PSAs go up. And the real way to do that is, okay, if I believe it could be due to what we call prostatitis or inflammation or infection in the prostate, that we treat that and then make sure we follow up that PSA again.
Thank you. Dr. Ani, you mentioned free PSA. Actually, that was one of the questions that we just received. Could you talk a little bit about what free PSA is?
Sure. When we do a PSA test, there are certain components, or in general, when you do a test through your blood serum or the bloodstream, you have a protein in your body called albumin, and the PSA is a protein in itself, and that protein can bind, meaning it can be attached to albumin and be carried through your bloodstream. There are some of them that are not carried through the protein called albumin. So as a result, they're free floating, or they're free, so to speak. So as a result, hence free PSA versus total PSA. Total PSA is basically the free PSA plus the albumin. So when you look at the free PSA, what you do essentially, you can utilize the ratio between the free PSA and the total PSA to determine what's called a percent free PSA. You can use that percent free PSA to get some assessments of the potential risk of prostate cancer. There was a study done by an author called Catalona, and I believe it's from the 1990s, where using PSA that falls between 4 to 10, when they studied these patient population with varying age groups, where it'll range from 55 years of age to 65, and then from 65 to 75, and you risk stratify them based on their percent free PSA, it suggested that if a patient had a PSA of less than 10%, the risk of prostate cancer can range somewhere between 5 to 10%. 55 to 56%. But if they had a PSA of greater than 25, free PSA of greater than 25%, their risk of prostate cancer is between 5% and 10%, or generally less than 10%. So when you have a patient that has a percent free PSA less than 10%, then you use that to counsel the patients in terms of their potential risk, combining that with your digital rectal examination, the total PSA, their family history, and now be able to get a little more information to be able to determine, is this a patient that warrants further additional evaluation, such as a prostate biopsy, an MRI of the prostate, and then be able to counsel them properly with what's called shared decision making.
Thank you. I'd like for both of you to consider this question, and you can decide who really wants to respond. What causes prostate cancer, and what are some of the risk factors?
As I mentioned earlier, the genetics, your genetic disposition, meaning what your genes are. And Dr. Ani talked a lot about family history, and that's what we mean by that. That means you have something in your genetic makeup that predisposes you or have a higher likelihood. As I talked about, exercise and high fat content and being overweight also increases your risk. And so they're what we call modifiable ones and non-modifiable ones. The big modifiable ones, at least that I've read, has to do with diet and exercise. And then the non-modifiable ones are your genetic makeup and your family, which is basically your family history.
Okay. Where is the prostate gland located? Which one of you would like to take that one?
I'll leave it to the urologist for that.
Well, the prostate cancer basically is located right below your bladder. It's a walnut-shaped gland, but it can get bigger as we get older, which is the reason that men tend to have the symptoms that they have associated with an enlarged prostate. And when we talk about enlarged prostate, it is important to distinguish an enlarged prostate from prostate cancer, because I think there is a misunderstanding that if someone has enlarged prostate increases your risk of prostate cancer, and that's not quite true. So you can have an enlarged prostate and not have prostate cancer, and the symptoms of enlarged prostate is not necessarily an indication that someone has prostate cancer. Unfortunately, prostate cancer does not have any symptoms. So a man can have enlarged prostate and have urinary urgency, frequency, prolonged time urinating, dribbling afterwards, and that be related to enlarged prostate. However, if someone has a pretty significant bad prostate cancer that is locally involving the neck of the bladder, that can also produce a similar symptom. But overall, the prostate is essentially located right below your bladder, and it encircles, think of it as a piping system that channels the urine right from the bladder to be able to be urinated out. And as the prostate grows, it tightens around that pipe. And as a result, the stream then slows down as we get older.
Thank you. Dr. Asher, you talked about exercise and diet. I'd like for you to go a little deeper in how important that is in terms of protecting and improving his overall health. Can you speak a little bit more about that?
Sure. I happen to be a hypertension specialist, so that's my area. And we talk about diet and exercise all the time. And what's great about diet and exercise in the conversation around prostate cancer, it also prevents other problems such as heart disease, kidney disease, and having strokes, which we're not talking about this evening, but also have racial disparities as well. And so when I think about diet and exercise, I think about the intake of the types of food you eat, as well as how much you eat, meaning we really know that obesity or being overweight increases your risk of pretty much every illness that we know of, including prostate cancer. And so therefore, trying to keep what we call our body mass index, or basically your weight, at a reasonable level is important. Then it gets into, okay, high red meats. We need to make sure that we keep everything in balance, lots of vegetables, moderation. There's not any food that I'm going to tell you, Dr. Ani might, but I don't think so, that you should eat to prevent prostate cancer. I'm not one of those Facebook guys that would say that at all. For me, it's everything in balance. The other good thing is that if you're exercising and watching your diet, you're also controlling your blood pressure. So I'm going to put a plug in for that, which also then helps prevent other issues that have disparities as well. And when we talk about exercise, we're not talking about buying a new jogging outfit, going to a workout place, being told to exercise by someone that is 40 years younger than I am, and leave there going, I'm never doing this again. It's really just increasing your exercise to about 20 minutes, at least 20 minutes a day of moderate exercise. I also, when TV clickers first came out, I tell my patients, put the TV clicker down, walk to the TV to change the channel. That gets you some exercise and also decreases divorces because you're not fighting over who has. So it's little things like that. Another example, and I'm just trying to give real life examples, is when you go to a store, don't park at the American dream is to get the closest parking space to the front door of wherever we walk into. Park farther away and walk to where you're going. All that counts towards exercise.
Thank you so very much. We will talk more about the importance of diet and exercise, and I'm so glad that you went as far as you did. A couple of more questions, and I'd like for either one of you to take it. If a man is treated with surgery, can he have a recurrence?
Yes. In general, we say if a man has any treatments for prostate cancer, whether it's surgery or radiation, there is about a 30% to 40% lifetime risk of recurrence. Now, that's a generalization. Part of it has to do with the stage of the disease at which the person was treated. If the cancer was truly localized in the prostate, the likelihood of recurrence is very low. But the difficulty of medicine is we don't have the technology to be able to detect microscopic cancer cells. So as much as we can say that prostate cancer is localized in the prostate and we can remove the prostate and we can have the pathologist look at it and look at the margins and say, oh, the margins are negative, everything is taken care of. Unfortunately, if there are any microscopic cancer cells that already are outside of the prostate, it may not necessarily detect it. And then several years down the road, and sometimes it can be as much as 20 years down the road, you may end up noticing the PSA starts rising up. So yes, you can have a recurrence. Now, the point that you have to consider, however, is it's important that even though you have had treatment for prostate cancer, regardless of what treatment you have, whether it's surgery, whether it's radiation, just because the treatment is over doesn't mean the care for the cancer is over, because that's how you can detect a recurrence and still have the chance to cure the disease a second time if you detect it early enough. When you don't detect it early enough is when it becomes a little more challenging. So, but yet to answer your question, yes, you can have a recurrence of prostate cancer even after surgery, but it all depends on the stage of the disease when it was treated, and that will make a difference.
Dr. Arnie, you mentioned cure the disease. When should a patient conclude that his prostate cancer has been cured? What are the signs? What is the information he should look at?
So, from the standpoint of surgery as a treatment, we use PSA thresholds to determine that. If someone has had surgical removal of their prostate, the PSA should be undetectable. And what we mean by that is the PSA should be less than or should be 0.05 or less. It needs to be 0.0 something. The error rate of the blood test for PSA is plus or minus zero point 0.5 is the error rate. So when it comes to surgery, if the person's PSA was 0.01, for example, 0.02, 0.03, and so forth, we consider that a successful treatment of the prostate cancer. And as long as it stays there, we consider the patient cured. If the patient's PSA were to be zero point 0.1, we still consider them undetectable. If it's zero point 0.2, we start wondering, is this an indication of a recurrence of prostate cancer? So now we start keeping a really close eye on that person. If it were to go to zero point 0.3, then we start saying there's what we call a biochemical recurrence likely, which means that this cancer may have been coming back. There are debates as to what threshold you use to make that definition, but between zero point 0.3 to zero point 0.5, we usually make a call and say, okay, this is probably a recurrence. We need to do something to try to cure the person again. Now, granted, you want to weigh what you're going to do at that point versus the status of that patient's health. So you don't want to do something if that patient is now in their 80s or 90s and have so many medical conditions. So you have to, again, have that discussion again with the patient, the family. But overall, the threshold is that it's 0.0 to call it undetectable. With radiation, it's a little bit different. With radiation, there is a definition that we use. So we use a definition where we want to know what is the lowest points that PSA ever got, and we call it a nadir. Then we follow the patient from there and keep checking their PSA. And we say the PSA needs to be 2 plus whatever the nadir is, or the lowest point is, to say this is a recurrence. The reason we do that is because with radiation, you're not removing the prostate. And as a result, the prostate will make some degree of PSA, even though it's been radiated. So the urologist usually, or any of the other doctors, radiation oncologists monitoring you, will keep track of your PSA. And that's the reason, again, it's important for follow-ups, so that if there is a concern for recurrence, that we identify it early enough.
Thank you. We have two more questions. The first one is, who do we contact? Who does a man contact if he wants to be tested and examined?
From my standpoint, their primary care physician or whoever they're seeing. So to be real honest, all physicians are trained, and all nurse practice, all extenders are trained how to check PSAs and how to do digital rectal exams. So it should be anyone they are seeing. Now, there's some specialists that probably don't want to do it. However, we all have the ability to do it and should be doing it, to be real honest. Now, you can get someone else to follow it up, but we all should be doing it. So you don't have to see a special type of clinician to have this done. You should be asking it of anyone that will listen to you.
Thank you. The last question is there any correlation between vasectomy and prostate cancer?
Well, the reason I'm smiling is because a lot of patients ask me that question when I do their vasectomy. Well, to answer your question, the answer is no. But a little bit of elaboration. The reason that that information is out there, there are two studies that was conducted to be able to see, is there a correlation to see if does vasectomy cause prostate cancer? Well, one of the things you have to recognize, there's a difference between association and correlation. Correlation means that there's a cause and effect. Association means you data mine the database and you found that there is association. So there is no data that shows that there is a correlation or cause and effect of vasectomy and prostate cancer. What's happened is, if you have a database of men that have prostate cancer, now you ask yourself, well, what's common between all these men? And then when you go back and look at the data, you find out that a good portion of these men also had a vasectomy. So then you think back, okay, well, if they have prostate cancer and a good portion of them had vasectomy, so therefore vasectomy causes prostate cancer. Unfortunately, you can't do that. Just as the same, you can also look at the same database and you can look and say, well, these men with prostate cancer, are they married or not? And then are you going to say, well, marriage causes prostate cancer? No. There's an association because those are the things that are associated with those people, but it's not a correlation. So the answer is no. There is no cause and effect.
Thank you.
And that is so important to remember because they all could have driven red cars, and red cars isn't causing prostate cancer. And so we have to be careful of that logic of how we work that logic through. And that is partly when the task force looks at its level of data, and when you have lack of data out there, you don't know. But from a true scientific standpoint, you should mine it, look at to see if there's an association, and do the appropriate studies to see if there's a correlation and then a possible cause and effect. But so we own that as scientists from the standpoint we shouldn't be using association data as causal, meaning just because that happened, that's the reason why you have it.
Thank you so very much, gentlemen. I'd like to thank you on behalf of the Hampton Roads Prostate Health Forum. This has been a delightful journey in understanding prostate cancer and all of the matters or all of the issues that impact it on a favorable and maybe unfavorable basis. We're going to wrap up now, and I would simply like to say thank you again to the two of you. Would like to thank our technology partner, Riverside Health System, and all of the folk involved in that activity. And I want to run the flag up and say, next week, next Monday, 8 February, we'll be back, and we'll be talking about the RESPOND study, and another urologist, Dr. Timothy Powell, will be with us. So hopefully you can share this with friends, and we'll continue to try to educate and make people more aware of prostate cancer in the Hampton Roads region. Thank you so very much.